For our session 2, we have three equally inspirational speakers, and the session is titled The How, the What, and the Why of Research. The first speaker is Professor Michelle Farrar. Michelle is a paediatric neurologist who's at the Children's Hospital in Randwick. She is internationally recognized for her work in translating innovative therapeutic treatments for children with familial neuromuscular disorders. Michelle is an established leader for clinical trials and has gone on to not only partake and develop multiple therapies for conditions such as spinal muscular atrophy and other neuromuscular diseases, but has also set up real-world newborn screening platforms which have significantly impacted the lives of not only New South Wales kids, but also kids around Australia. Her long-term and outcome studies, including health implementation and health economic analysis, measures of benefits and harms, and development of models of care, have greatly informed government policy, which is most important. Michelle is one of the next gens, as they call it in tennis. She has published impressively over 85 scientific papers, and that's very hard to do with a young family. Most of these publications have been in highly impressive and influential international medical journals, such as the New England Journal of Medicine, Nature Reviews Neurology, Lancet Child, to name a few. She has also received multiple accolades and awards for her outstanding research, including the highly prestigious Leonard Cox Award from the Australian and New Zealand Association of Neurologists, recognizing her outstanding contribution as a clinician research scientist. So Michelle will talk to us about pediatric neurology, the dawning of a new era. Thank you, Michelle.
Thanks, Steve, and good morning, everybody. I've thoroughly enjoyed the presentations today. So as Steve has kindly said in his introduction, I've been very privileged to be involved in developing the first genetic disease-modifying therapies for motor neuron disease in children, and really witness the clinical transformation that has followed. I guess it is the dawning of a new era, and this has provided a proof of principle that genetic therapies can be safe and effective. So today I'm going to share my journey and really why it's a really important time to pursue life as a clinician-scientist, and explain my journey, the how, the what, and the why. And really, I've spent a lot of time over the last few weeks doing jigsaw puzzles, and it's really been a journey of doing and building a jigsaw puzzle, being organised, being ready, approaching it from very many sides, using a team, building new skills, thinking about the challenges, thinking ahead, being ready, and enjoying every single piece of it. So I started focusing on the clinician part, and this was a 15-year journey. It was from undergraduate medical student at Sydney University, moving through the hospital system and my fellowship in child neurology. There's been lots of long hours on that journey, especially in the last 2 years of my training, where I worked 12 out of every 14 days. I was first on call for 7 of them, and I fielded statewide referrals. And really, this was so important in solidifying my clinical skills. But it was in the last year of my child neurology training that my colleagues were planning placements overseas. They were going to Cambridge, they were going to Boston, they were going to Toronto. I was newly married, I was in my 30s, and I wanted to do something different to clinical medicine, but really wasn't able to take the step to go overseas. And I turned to research, which was interesting to me. So at the time, I had a number of conversations with senior colleagues, and they were offering advice, potential supervisors and topics. How about epilepsy? How about ataxia, neuropathy? I thought about spinal muscular atrophy because as a clinician, I'd cared for children with SMA. All these babies had died, and I'd been involved in telling the parents that there was nothing that I could do or anybody could do to change their child's life and save them. You keep your ear to the ground, and I knew there was promising research in the lab, and we'd gone from knowing the cause, identifying the gene in 1995, and over the next decade, there'd been rapid advances in understanding the molecular mechanisms, and preclinical therapeutic development was emerging in the labs with antisense oligonucleotides working on a dry base in 2006, working in cells in the year after. And that's really when I entered the scene. And there were animal models of therapies starting in 2009. So spinal muscular atrophy is a motor neuron disease. You can see the muscle weakness and the respiratory insufficiency of young babies, and the loss of motor nerves in the spinal cord. And I think at the time in Australia, clinical trials in neuromuscular diseases were focused in muscular dystrophies, myopathies, and I really recognised the high unmet need and the need to develop clinical trial readiness for spinal muscular atrophy. So what next? I needed to find a supervisor. There wasn't an expert in SMA in Australia. I talked to a number of people and really thinking outside the box. And I still remember my first conversation with Matthew Keenan. He was a world expert in adult motor neuron diseases. I said, "Hi, do you have a minute? I want to do some research, probably do a master's." He said, "You're wasting your time. Don't do a master's, do a PhD. It's better." I said, "What about SMA?" I didn't think he'd be interested because as an adult neurologist, these kids didn't survive, you didn't see it. And he went, "Oh yeah, let's do it." And that's what set us off. So really the message is pick a supervisor, maybe outside the box from where you are at the time, someone that's interested, someone that's helpful, a topic that interests you. And over the next 9 months, we planned the projects and we applied for funding. I was awarded an NHMRC scholarship and I started my PhD in 2009. I was also offered a clinical job, and Matthew gave me some very good advice at the time. He said, "Cap it, don't do more than 1 day a week. You need time to think when you're starting out in a research career." And really, this worked well. I could recruit patients clinically, but also not be overwhelmed by the demands of a job. And so at the end of my PhD, I'd studied the natural history of the Sydney cohort, gathered together the cohort of patients, gained insights into the pathophysiology, and also 2 wonderful children. It was a great time in research to start a young family. So my research and clinical work brought around interest from industry, and it was an invitation to lead an Australian clinical trial site for SMA. So I formed a clinical trials team really driven by the prospect of change. Phase 1 trials had commenced in 2011, around the time I was submitting and finalising my thesis. And in 2013, I focused on the infrastructure and the resources within the neuromuscular clinic for the study. It was a randomised, double-blind, sham, placebo-controlled study looking at the safety and the efficacy of a new compound called ISIS 396443. It was administered intrathecally to young babies who were paralysed with SMA. I remember the comments from my colleagues, "Do you know what you're doing? Don't make it worse." The sponsor changed their name from ISIS Pharmaceuticals to Ionis, and we opened the study. And really the message here is, however hard it is to open a study and to it's harder for the patients and family. And this is what drove me to keep going. We need to be brave, back the science, use your knowledge, bring change. I wanted to bring solutions. I wanted to bring hope. The first patient that I enrolled died. The best we ever saw them was in screening. Then they deteriorated rapidly. They were writing the textbook of SMA as I knew it at the time. I was on the blinded team. I didn't know which arm they were on. It was even harder to recruit the second patient knowing that. Her mum would pass us the baby. They'd go into this treatment room to the unblinded team and she'd stand outside crying. And I didn't know what was happening inside. I had to comfort her. But then something astonishing started to happen very slowly. She wasn't deteriorating. It was very subtle. She started wriggling. Then she started kicking her legs. Then she rolled. She held her head up. And then she sat. I'd never seen that before. I felt like we had a big piece of the puzzle, but there's a lot more to do. So the lack of treatment was addressed. We had the first disease-modifying therapy for SMA. It was now called nusinersen. It's an RNA therapy. It's a small strand of nucleic acids. It binds to the mRNA. It changes the splicing of the SMN gene and it produces the missing protein. We treated the 9th infant in the world through a global compassionate access program. And I think really in taking it forward, clinicians, researchers are such an important link between the community and the government and the industry. And we oversaw the introduction of such a complex therapy through national practice into clinical practice. And it was in 2018 that it was PBS listed, and we started administering treatment to all asymptomatic patients. And this is me doing the first PBS listed treatment to one of the children I cared for with both their parents. And it really just, they photobombed me. I wasn't expecting this photo to be taken. And I really like it because it shows why we do it. It brings hope, it brings change for the future. But really, this was the start. It's another piece of the puzzle, but there's so much more to do, so many more questions, so many more uncertainties. But at the time, there's no roadmap for the rest of the puzzle. You do the best you can at the time, but you ask, how can I do this better tomorrow? Can we run ahead of SMA? Can we keep changing the landscape? And so really it's important that we're providing care, but we needed early detection. We needed to diagnose children before the horses bolted. It's a motor neuron disease. The clock is ticking. And there had been, at the time that the clinical trial I'd been involved in was published in the New England Journal of Medicine, there was another paper right alongside it. This was describing a single centre phase 1 clinical trial of a single dose of gene therapy in 15 infants. I knew the study needed to be replicated. I needed to keep working on the pieces of puzzles. So I joined with a colleague, Ian Alexander, who had 25 years experience in gene therapy research. And together we engaged industry again. We really wanted the opportunity to bring these clinical trials to Australia. And fortunately, they were asking the same question that we were asking, how can we do better? They were planning a gene therapy trial in babies with SMA aged less than 6 weeks old with no symptoms. That's a huge challenge, but we were really fired up, and we set in motion a statewide newborn screening pilot to really leverage the trial. And we were driven by the science, the team, our clinical skills, and the hope for change. So at the time that we embarked on this, only Taiwan and 3 states in the US were planning or initiating newborn screening for SMA. All the literature to date had focused on the assay performance in the lab. And an important component of our implementation of statewide population newborn screening was looking towards the future to be able to answer the practice and the policy requirements for potential inclusion of SMA as a routine element of newborn screening nationally following our pilot. So we were strategic. We thought about all the elements. We set in place research within the clinical realm to look at the screening test performance, the availability of treatment, the newborn screening pathway, the model of care for newly diagnosed babies, the costs and the impact on their health outcomes. And really in parallel with this, we initiated the gene therapy trial. And really the highlight in all of this work for me was working collaboratively across many different teams with different skills and really learning new skills along the way. And I worked with scientists, health economists, implementation scientists, hospital executives, policymakers, and they were all wonderful partners to have. And so today we've now screened over 300,000 babies over the last 3 years. We've gathered scientific data to answer each one of these elements and questions. The clinical trial's finished. It's going to be published soon. And in May this year, the Commonwealth Government recommended that SMA be added routinely to the National Newborn Screening public health programs. So I think we've heard this morning already, but I again want to highlight how important patients and families are. They highlight the issues, they set the agenda, and as clinicians, we're in such a privileged position to take these issues back to the science and really answer them to improve care for tomorrow. I see people at their worst and I ask, what can I do to learn from today to make tomorrow better? Aviana at the top is the 9th child to receive nusinersen in the world outside of a clinical trial. She flies down from Sydney to from Darwin. And at the time that she started her therapy, she was on the front page of the Sydney Morning Herald. And I was really surprised at the time by the headline, "Sometimes we sit and cry." And really it was listening to the families. They had a new therapy, their babies' lives could be changed. But what the families were saying is, we didn't know this could happen. Why hadn't you told us? We try really hard to be happy for her, but after we put her to bed, we just sit and cry. And the same question kept coming as I was diagnosing babies and they had symptoms and I was initiating treatment. Mackenzie's family down the bottom experienced the same devastation and asked the same questions. And really what this taught me is that the best care depends on the situation in front of you. It can be reactive care, starting a new therapy to save a baby's life. It can still be palliative care or proactive care with newborn screening. But preventative care was a really important question that families just kept asking. And so Mackenzie's parents promoted awareness about reproductive carrier screening. They were in the media a lot. They wrote many letters to government. And I was working with a wonderful group of clinician researchers who also believed that preventative care was very important. And everywhere the government went, they heard the same message. And really, I think what I'm trying to say is that important things can happen when we work together as a team with clinicians, researchers, and patients. We talk to each other and we listen. So we were all invited to sit down and talk about this with Minister Hunt, discuss our experiences, but we also came with a solution, and that was Mackenzie's mission, to undertake clinical research with a population-wide reproductive carrier screening. That's testing 10,000 couples around Australia for around 500 genes that are associated with severe genetic diseases. The research is aiming to prepare the Australian health system at scale for screening, to give families and couples planning to have a child choice so that they're not blindsided and devastated and asking the same question, why weren't we born? So on a personal note, the why, it gives me great joy to celebrate the milestones with the patients and the families I care for. First birthdays, second birthdays, third birthdays, they just keep coming. The baby whose mum who cried outside the door in the blinded RCT is now in kindergarten. She's very much a loved daughter and a sister in her family. I'm deeply moved by how incredible the parents are in the worst possible situations and moments in their life. And as clinicians and scientists, we try to do the best for each situation in front of us. As a child neurologist, the why is because it's especially challenging to be faced and confronted. Feel your heart sink as you know you have to go and tell a family there's nothing you can do. There's always something you can do. And as a clinician scientist, you ask, how do I change this? It's an opportunity to keep learning, to do your best, to work as a team and to share the wins. So as a PhD student working with Matthew and Steve, I'd often see their talks and the slide that they would show, which was the quote of Charcot, one of the fathers of neurology. Let us keep looking, in spite of everything, let us keep searching. It's the best method of finding, and perhaps thanks to our efforts, the verdict we give a patient tomorrow will not be the same as what we must give them today. So therapies based on genes are having a profound effect in my field. They're also showing the power of genetic therapies more broadly. And there's so much to be done and so many more questions that I hope you'll be inspired to join to help put the pieces together. And really for me, the puzzle is about many supports that I have received along the way. And firstly, my wonderful family. My husband has been my greatest supporter, encouraging me to keep going, and my 3 beautiful children and my COVID puppy. My mentors, and there's many of them, Matthew, Steve and Adam. And really, I learned something very important from them. I was always worried that I wasn't keeping up with my peers, but they've taught me that as a female in medicine, it's different. It may take longer, but that's okay. Just do your best. The team that I work with, who inspire me, and my many collaborators. And it's not just in medicine, it's a diverse group of people, and I thoroughly enjoy working with them and learning the new skills. And definitely the patients and families I care for that give me inspiration, ask the questions, and the funders that have supported me. Thank you.